Welcome to ATCM, the Emergency Medicine channel. Today I will be presenting a infectious disease case to you. It is a case of leptospirosis.
Oh.
65-year-old male patient was rolled into ER with complaints of fever, myalgia and breathlessness since the last 1 week.
Can you tell differential diagnosis for fever with myalgia?
Mostly it will be seen in viral fevers. In this COVID pandemic, we should suspect COVID also. Then dengue fever, leptospirosis, chikungunya and all will be having myalgia.
Okay, non-infectious conditions?
Polymyositis, rhabdomyolysis.
Polymyositis is okay. Rhabdomyolysis is a part of other disease, Still's disease. There it is predominantly joint pain, but even then they can also have muscle pains. Okay.
Fever, myalgia and
breathlessness. Initial 10-second assessment, patient was conscious, oriented and obeying commands. The airway was patent, there was no pooling of secretions or gurgling. Breathing, his respiratory rate was 40 per minute and he was maintaining saturation of 96% with 6 liter O2 with which he was brought from an outside hospital.
Can you tell causes for tachypnea in ER?
Physiological causes are anxiety, pain, fever and all. Then other causes like respiratory and non-respiratory causes. Now, respiratory causes like pneumonia, COPD exacerbation, bronchial asthma, etc. And non-respiratory causes like cardiac causes. And other causes are metabolic causes, metabolic acidosis causing tachypnea.
Oh.
So, oxygen 6 liters by
face masks.
face mask.
Air entry was bilaterally equal and there was bilateral diffuse crepitations heard. His chest exertions were increased, sir. He was using his neck muscles, sternocleidomastoid and scalene muscles were used. Intercostal indrawing was there and he was also using his abdominal muscles to breathe.
What is the level of consciousness?
He was fully conscious and oriented. He was maintaining saturation with 6 liter O2. I asked to arrange a BiPAP also and I proceeded with the circulation.
No, this is a question. When you are having a patient who is having saturation, good saturation, according to you, saturation is good. On 6 liter oxygen, why you want to prefer a BiPAP in this patient? You are correct, but you have to tell why.
Actually his oxygenation is maintained, sir, but his respiratory efforts are increased, sir. So to supplement that we should arrange.
Patient is having tachypnea, respiratory distress, even then the saturation is good, maintained on oxygen. This patient is going to crash immediately if you don't put him on a higher level of oxygenation, because his saturation is good but his efforts are more, so he is going to crash. So that's why we have to start on BiPAP or mechanical ventilation depending on the scenario.
Circulation, his blood pressure was 110/70, MAP of 80 and heart rate was 106 per minute. All peripheral pulses were felt equally and bilaterally and there were no hemorrhages at present. Disability, his GCS was E4, V5, M6, pupil was 2.5 mm reactive with a GRBS of 189.
Clinically, how do you know that patient is having thrombocytopenia or bleeding tendency without any rashes on the body?
We can do HES test and see.
Test is very important clinical investigation, can be practiced in a rural setting or non-urban setting where these investigations are not available.
We can inflate a BP cuff more than the systolic BP and wait for 5 minutes, and after that we should see for the PETK. If there are more than 5 PETK, that is significant of thrombocytopenia.
5 or 10?
10 is normal, means 10 is abnormal.
Exposure, his temperature was 98°F and hypothermia was prevented by blanket. Urgence, at this point of time patient was kept in a proper position and ABG was asked for. ABG was showing a pH of 7.33, PCO2 of 34, bicarbonate of 80, PO2 of 107 actually, and lactate of 2.3, creat of 4.73 and anion gap was 12. So he is having a metabolic acidosis and the tachypnea is mostly because of this metabolic acidosis.
Why you think that this patient is having metabolic acidosis?
Maybe he is having a renal failure also. So already creat is high. So
here in this patient we always suspect renal failure or lactate how much?
2.3.
2.3. Okay. It is not very high, so we have to think about renal failure. Okay.
Hydration status, urine output. Normal.
We are coming to that,
Next
sir, but
point,
so
okay.
far in the history it was actually normal.
No,
Sir.
okay, good.
We have asked for chest X-ray. Then we did a bedside ultrasound. A bedside ultrasound in IVC was checked. It was 2 centimeter dilated. LV functions were good and bilateral B lines were present. Sir. Then 2 large bore.
B lines, how do you diagnose it is abnormal?
Normally there we can see some B lines, but if you are seeing a B line in one single plane, or if you are seeing more than 10 B lines in one lung field, then that is significant.
If you are seeing in multiple areas itself, you should suspect there is a problem. The diagnostic criteria what you told is correct. If you are seeing in multiple areas the same picture, then you have to suspect pulmonary edema.
Then 2 large bore IV cannulas were placed, and blood samples were collected for CBC, RFT, LFT and coagulation profile. And since there is history of fever and there is an organ involvement, we already know with this creatinine. So we've taken 2 blood cultures, 2 aerobic blood cultures was also taken. And
what is the ideal blood culture to be taken in a sepsis case? Ideal. You have taken only 2 aerobic.
Anaerobic blood cultures.
Ideally, we have to take anaerobic culture also, but we are not taking because it's costly, and many times we never get anaerobic blood culture. Whatever antibiotic we give, that mostly will cover anaerobic, but ideal situation we have to take 2 aerobic, 2 anaerobic. Okay.
Then when he is having a tachycardia of 106, one ECG was also taken, sir. It was showing sinus tachycardia. Then I went ahead with the ample history. He doesn't have any allergy. He is a known case of diabetes. He is on mixed chart 30, 70, 20 in the morning and 30 at night. Last meal was taken 5 hours back. Events, he is a farmer.
Ideally, when you are giving mixed chart is a mix of rapid acting insulin and short acting insulin. You are giving 50 units. What is the ideal dose to be given if you are giving 2 times dose?
More in the morning and less in the night.
So it has to be 30-20 than 20-30. That is the correct way of giving. Because night time the amount of food taken is less. Maybe on night time 1 meal you are taking, but daytime at least 2. Some patients may take 3. So more dose should be given. Around 60% of the dose should be given in the morning itself if you are giving daily dose. Okay.
See any other hypertension or ischemic heart disease?
No other comorbidities. Events, he is a farmer by profession and no other habituations. He had a history of myalgia since the past 7 days associated with fever for the initial 2 days. It was high grade fever associated with chills and rigor. He took some medications for this myalgia, paracetamol and all, but NSAID intake is not known. After that he developed breathlessness since the last 2 days associated with cough with white sputum. There was no hemoptysis, and his breathlessness worsened from NYHA grade 2 to grade 4, and there is no other history of chest pain, vomiting, loose stools, etc. or hematuria, and no history of reduced urine output. He is having good urine output. That was a history, sir. So we went ahead with the head to foot examination. There was no pallor, icterus, cyanosis, lymphadenopathy or edema. Central nervous system examination was within normal limits, sir. He had minor some pedicle lesions over the skin, sir, and he had some healed wounds over the lower limb also.
Any other finding in the eye conjunctiva?
Conjunctiva, ideally we should look for some subconjunctival hemorrhages, and icterus also should be checked.
And redness, suffusion.
Redness is very important.
In leptospirosis there can be conjunctival congestion initially, and in the non-icteric phase there can be uveitis also. That all should be checked, sir.
That is shown pertinent negative. Okay. No pertinent negative, you can just pinpoint.
In the respiratory system examination inspection, trachea appeared central, chest movements were normal, there was but use of accessory muscles of respiration were there. Bilateral air entry was equal with bilateral crepitations. Cardiovascular system was within a normal limit. Abdomen examination also there was no organomegaly on palpation.
The respiration you can add the neck examination, any distended jugular veins.
At this point of time we have a case of fever, myalgia, breathlessness and renal failure. So it will be mostly in this climate we are expecting a leptospirosis, so it can be a leptospirosis or any other viral infection, or it can be an LRT causing this acute kidney injury, sir. So
how was the urine output?
History wise urine output was good, sir.
Good. Non-oliguric.
Yes, sir. Then he also had some petechial lesions, so we should suspect thrombocytopenia or other coagulopathies. So we went ahead with the investigations. His hemoglobin was 13, platelet count was only 27,000. So we sent for a peripheral blood smear which was showing a platelet count of 30,000, manual platelet count. Total count was 16,000 with a CRP of 216, procalcitonin was 12. It was raised, so mostly a bacterial infection. Sodium was 136, potassium of 4.4, even though he is having renal failure. Urea was 163.6 and creat of 4.75. It is coming as renal cause. And his total CK was 965. It was elevated, sir. Then bilirubin was 3.19 with a direct component of 2.55 and SGOT, SGPT was 127 and 128. Albumin was 3.72 and globulin of 3.3. So no AG reversal, so maybe an acute cause. And coagulopathy markers were normal. INR was 1.05, APTT was 25. A chest X-ray was taken. Chest X-ray was showing bilateral diffuse infiltrates was seen, sir. So he was after doing in this pandemic we should do a COVID test. So after doing the COVID gene expert, it came to me negative. So he was admitted in our ICU, and we reassessed the patient. On reassessment, his airway there was some oral secretions and it was slightly frothy and hemorrhagic, sir. After then his respiratory distress worsened after some time, and he was maintaining he started desaturating with oxygen mask, so he was converted into a NRBM, but still he was desaturating and his respiratory efforts were also worsening.
So how was the time interval between you received the patient and the respiratory status is deteriorating?
It was deteriorating from the time he came. It was slowly gradually deteriorating.
How many minutes are what is the time lapse?
45 minutes. Within that 45 minutes time it was worsening.
Why I am asking, once you are seeing a patient, there are different types. The one is dyspnea or breathlessness. This patient will progress to respiratory distress. That is an impending respiratory failure. At this stage, we should take appropriate measures to prevent any further hypoxia. So we can in anticipation go for endotracheal intubation at this stage itself. We need not have to wait till the oxygen drops. SpO2 is in fact is not a good indicator. Okay, go.
That time his heart rate was 130 per minute and blood pressure was remaining same only. He was in an impending respiratory arrest, so we planned for rapid sequence intubation, sir. Since his hemodynamic status were normal, we selected analgesic as initial analgesic as fentanyl along with an induction agent etomidate. Since he was having tachycardia, we didn't go for ketamine, and he was not having any bronchoconstriction features also. Then for paralysis, we selected rocuronium.
How did you pre-oxygenate the patient?
He was on NRBM, sir. So with NRBM, he was not maintaining much. He was maintaining only 70 to 80% saturation.
So in NRBM, he was deteriorating.
Okay, good. So we should go for bag and mask, but we should be careful that he was having some oral secretions which was hemorrhagic. So we should be careful about that, sir. Then During intubation also we should be very careful about the bleeding. Since his platelet is only 27,000, there can be bleeding trauma and all. And if we are not giving adequate analgesia and paralytic agent, if the patient is struggling during intubation also, that can worsen the bleed.
Very good. Okay.
And we should avoid unnecessary suctioning also. Only adequate suction should be done. He was intubated with an 8-size endotracheal tube, and angle of mouth was secured as 22. Post intubation from the endotracheal tube, he was having bleeding from the endotracheal tube, sir.
What it indicates?
It indicates either because of thrombocytopenia or leptospirosis can cause pulmonary hemorrhage.
Normally, when there is thrombocytopenia, you can see the bleed when you are intubating.
Intubating.
There you can see the while suctioning and all, you can see. Otherwise, when the tube goes in and continuously, if the blood is coming, which is frothy, then you have to strongly think about alveolar hemorrhage. One of the worst prognosis of leptospirosis is this one.
Then he was given Tranexan nebulizations, and we also arranged for platelet also. By that time his metabolic status was worsening. His pH became 7.1 with the potassium of
is there any indication for tranexamic acid nebulization, this type of situation?
Actually it is an antifibrinolytic, but we can give an acute bleeding, but actually we should give platelets also. But alveolar hemorrhage we cannot stop by this.
It will not be stopped. This is a systemic process. It will not be stopped by a nebulization. However, it is given. Okay.
And we have sent for one IgM leptospira test, sir. Since the fever started like 1 week back, it is almost time for the IgM to become positive.
What is acute presentation? What are the investigation you do to diagnose?
In acute presentation, you can do a dark field microscopy in the urine and find, and or PCR test can be done.
Is the easiest thing, but in a primary care setting, it is easy to do a dark field microscopy. That can be, you can see motile leptospira in
that. It came as a leptospirosis positive, sir. So IgM leptospirosis. So this our patient.
What is the units in that? Our lab shows more than 10 is positive. So that is very important. When see somebody is having, there are different types of leptospirosis. One is clinically what we are seeing, a leptospira ectohemorrhagica or introgans. In that, all these clinical features will come. There are some other leptospira which are present in the environment, which will not present as a disease like this. They will just infect you, small symptoms maybe there, they disappear. Even in that condition also, this can be positive. So somebody is only having leptospira IgM positive doesn't mean that he is having leptospirosis or Weil syndrome. Clinical correlation is very important for all these IgM tests. So that and the units are very important. If the units are very high, that indicates a strong infection. If the units are very low, it may be anamnestic reaction, an old infection, or some other non-pathogenic leptospira infection. So units are very important. Here, this is a clear-cut case of leptospira. There is no doubt.
So you have chosen the drugs. You have intubated the patients. What else you have to keep in mind with this in regard to the patient is having pulmonary hemorrhage?
Sir, when we are setting the ventilator, we should set in a high PEEP with the low tidal volume. Setting should be arranged, sir.
How much tidal volume?
Around 6 ml per kg
so
of the
same
ideal
as for
volume.
ARDS.
Yes,
okay, lung protective strategy
ventilation.
should be so in order to prevent further damage and further hemorrhage. And intravenous fluid management also should be very judicial. Okay, good.
This patient is in leptospirosis in the non-icteric phase with complications. Weil's disease is there, renal failure is there, jaundice is there.
Leptospirosis with non-icteric phase.
In the second phase, sir. No.
Second phase is icteric phase.
Initial
phase is non-icteric phase. That is a leptospiro. That phase is otherwise called as leptospiremic or leptospirosis phase. There is no antibody. Second phase, antibodies are formed. Your IgM is positive that time. That antibodies will act against liver, kidney, and brain, and any other organ. So this patient is in that phase.
Icteric phase.
Icteric phase or immune phase. Some patients may not have jaundice, so we cannot exactly tell it is icteric phase. But that phase you get all immune mediated diseases like liver failure, kidney failure, encephalitis. Okay.
So he's in the icteric phase with liver involvement is there, renal involvement is there, and pulmonary hemorrhage is there. And post intubation, even after adequate sedation and paralysis, he was having tachycardia or of around 150 to 160 range. So maybe myocardial involvement is also there. So with this he was in the ICU, and now airway is secured, breathing is also secured, and he's having tachycardia, and at present blood pressure was also maintained. In view of worsening of acidosis, we have to plan on a dialysis also. Acidosis is worsening, so dialysis was also planned, sir. And during dialysis he went into hypotension, so we have started him more noradrenaline support. Already he was in fluid overload state, so we didn't go ahead with much fluid. So we started him on noradrenaline support. Even after dialysis, his tachycardia was worsening, and he had hypotension also.
So what drug you can add with noradrenaline?
We can give cardioselective beta blockers can be given.
No, that is okay. I'm not asking about that. Somebody is having hypotension, you have started noradrenaline. Now the heart rate is 150. You have to add another drug.
Vasopressin should be added and the dose of noradrenaline should be
Reduced.
Which one more?
So when you start vasopressin, why you want to reduce the dose of this one? See, when you start noradrenaline, you have to see what is the BP. Now the patient has gone to heart rate of 150. What is the BP at that point? What is the BP?
It was around 80 or 50, sir, with the noradrenaline.
Okay, so what is the next drug you vasopressin can be added? You told vasopressin, that's okay. But why you want to reduce the noradrenaline dose when you are starting vasopressin?
the rate. Norad mostly won't cause much of a
It will not
tachycardia.
produce much tachycardia.
But if at all just if we control the rate, the output can be more better.
No, that is okay. Why you reduce the noradrenaline and increase the dose of vasopressin? Is it like that?
Vasopressin we start at a dose of like around 0.03 unit per kg like that. For about 60 kg it will be like 1.8 unit. That dose we'll start. So when we are titrating the like if the patient's BP is improving, while we titrate, we can titrate of norad first like a bit, then like reduce the vasopressin.
Is it guidelines to say like that?
You run it as such without reducing. See the BP response.
Normally we don't
Once it
reduce.
is,
Once you get an adequate
Desired,
BP, then you
then-
can try to reduce.
Okay.
Normally we don't reduce and add another drug. We add another drug. Depending on the response, we can titrate the dose of the drug. Okay. Okay. So what drug you have started for this patient? Second line.
Sir, beta blockers can be added, sir, but there is again a
Beta
problem of
blockers, how do you start? What beta blocker you want to start? Why you want to start? How do you progress?
Cardioselective beta blockers can be started. So carvedilol was started, sir,
Okay.
3.125.
What are the indications? In sepsis, it can be started, but how do you monitor the patient? Because beta blocker itself can produce hypotension.
So we have to slightly increase the supports, and then we should give the beta blocker, sir, and we should monitor continuously. Ideally we should place an arterial line, and full time we should monitor the arterial BP, sir.
Okay.
Then that was started, and he was not improving with that. Or we can select funny sodium channel inhibitors like ivabradine also can be started. That will not reduce the blood pressure. That will
can
only
reduce the heart rate.
Heart rate.
Okay.
That was started.
So you have started noradrenaline. You have started vasopressin. What is the next line of management?
Then we have to give the ventilator settings also we control. Now we will have to give the antibiotics, sir.
Sepsis guidelines say first line drug noradrenaline, fluid. Second noradrenaline. Third, add one drug to noradrenaline. Fourth is what?
Steroids.
Okay, you have to add because that is a guideline. You go according to that. If there is no contraindication, suppose sugars are very high, then that's a contraindication. Otherwise, what is a contraindication here? There is no
No
contraindication.
contraindication.
So you have to add steroid.
Steroids.
What steroid? What dose?
Hydrocortisone, 200 milligram stat dose can be given, sir.
Okay.
Whenever we are thinking about the second
Okay.
anodrop, and then we can continue it as 50 mg 6 hourly. It should be continued.
Okay. So they all should be given. If there is a contraindication, you avoid that one. Okay.
Then after so circulation, that was about for, and disability, he is having infection, so we should start him on antibiotic. So if it is a leptospiro, it will respond to any antibiotic, but there is lung involvement and all, so we should plan on a higher antibiotic to avoid further infections or respiratory.
Actually, it is not recommended. See, recommendations are very clear. It is a leptospirosis, whether it is pulmonary hemorrhage or ARDS. The antibiotics are same. Antibiotics will not reverse the process in leptospirosis. It will only kill the bacteria, but it will not reverse the immune phase. So antibiotics are same. If you are thinking about another bacterial infection due to ventilation or hospital acquired infection, then only you have to go to higher antibiotic. Otherwise, message should be very clear. You should start a basic antibiotic like crystalline penicillin, amoxicillin, azithromycin. They all will kill leptospirosis. If you are thinking about an add-on infection like ventilator associated infection, then add another drug.
So he was started on doxycycline 100 milligram twice daily BD dose, and he was started him on ceftriaxone also, third generation.
For leptospirosis, single antibiotic will be enough. Ceftriaxone alone will be enough. Doxycycline in renal failure, some physicians may not prefer. They are not contraindicated. Many doctors may not prefer patients on renal failure doxycycline. Ceftriaxone alone will be enough to control the leptospirosis, but not the immune phase.
Then his urine output in circulation, but the urine output also should be monitored, sir. Already his urine output was good only, but first dialysis was done in view of worsening acidosis, sir. Then when we have monitored him, he was still persistently having hyperkalemia, sir.
Okay.
So hyperkalemia.
What was the level?
Initial potassium level was only 4.4, but there was worsening of potassium. It became 6.5, 6.7, like that. It was
so what do you do immediately when you are seeing 6.5 potassium? What is the immediate step for a ER physician?
So we can give either shift the potassium cardiac.
ECG should be taken. Taken ECG, see any cardiac abnormalities. Your treatment is different. Treatment should be started in acute renal failure with hyperkalemia. You have to take an ECG or see the monitor whether any changes are there or not. What changes you anticipate?
Tall tenor T waves should be there. Then there will be prolongation of the PR interval, QT interval prolongation.
So how do you started treatment for this?
So he was already on a cardiac monitor, and he was having sinus tachycardia with tall T waves. So we should give the anti-hyperkalemic measures. Calcium gluconate should be given, sir. 10%, 10 ml IV over 10 minutes. Then we should give GI boluses. That means 25 dextrose with 8 units insulin should be given. And since if he is in severe acidosis with a pH less than 7.1 and all, we can think about giving soda bicarbonate. But ideally, it should be given only in case of cardiac arrest secondary to hyperkalemia.
So here the patient is already on dialysis. That may take care. Even then, you have to give calcium gluconate.
Then for output is there, Lasix also should be given so that it can be excreted. Then nebulization with salbutamol should be given so that the potassium will go into the cells.
Okay. So in this patient with tachycardia, how you told heart rate is too much.
Yes, sir.
The role of
nebulization. Salbutamol nebulization itself can cause tachycardia, worsening of tachycardia.
So for hyperkalemia, giving salbutamol nebulization may not be very good choice. We have better drugs. Whenever like patient is having tachycardia, again it may increase.
So we can consider levosalbutamol or
even then it will increase. Levosalbutamol also it will increase, but better to avoid because high dose of salbutamol nebulization is required. We have better drugs.
that should be taken care. That was taken care of, and we were planning on a repeat dialysis. After 24 hours itself, we went for repeat dialysis. He was having this thrombocytopenia with bleeding manifestations, so we have transfused him with platelets also, sir.
What are the bad prognosis in leptospirosis?
Bad prognosis is worst prognosis will come for ARDS, pulmonary hemorrhage, myocardial infarct, myocarditis and all, and renal failure, which is not responding even after dialysis and all. Sometimes the patient will go for hypotension, refractory septic shock, acidosis, hyperkalemia, hyperkalemic cardiac arrest, these risk factors.
And vasculitis, especially pulmonary vasculitis and necrosis. And the patient was maintaining saturation and on ventilator.
Yes, sir.
Everything was going on. Okay, thank you.
After that, pulmonary hemorrhage, that part was getting controlled, sir. But after 24 hours, what happened is his hypotension was worsening. So we couldn't, we added on support, but we couldn't save him, sir.
Okay. So one of the most important complication in leptospirosis is pulmonary hemorrhage. In X-ray, when you take the X-ray itself, you can make out. See, ARDS and pulmonary hemorrhage differentiation from X-ray, this will be more bright in color than heart, like same like heart. The ARDS will be slightly lower in intensity. Other one just looks like heart, means heart shadows. That brightness should think that there is a hemorrhage. The deterioration is very fast. You may not be able to save the patient.
And regarding the antibiotics and doxycycline and azithromycin, when you are in doubt, not able to pinpoint whether it is leptospirosis or rickettsial, then this choice will be better other than other antimicrobials, doxycycline and azithromycin. One of the important thing with the doxycycline is it's contraindicated in pregnant ladies. Okay.
Okay, sir.
Okay, sir. Good.
Thank you.